Good morning, ladies and gentlemen. I'm Golly, the Chancellor, and I'm very honored to be here for the 8th Annual Woodard Symposium, and I am most honored to welcome Dr. Pascal Jabbour here this morning. I read Dr. Jabbour's CV quite extensively, and actually a lot of the seminal work he did in the therapy of retinoblastoma. But the thing that really kind of stuck out was his background and the fact that he's I guess you're the president now of the World World Association of Lebanese Neurosurgeons, which I don't think I can ever join that. But the interesting thing is that, I had my second birthday in Lebanon, as most of you know. I'm from Iraq originally, and I left there when I was about 3 years old as a kid with my parents, so my mom could come to the U.S. and get her PhD. And then the war broke out at that time, and things kind of deteriorated, and so we ended up staying in the U.S. But I had my second birthday in Beirut, and I have a picture of that. So I think it's really kind of neat. And I had a chance to speak with Pascal here in some Arabic just a little bit ago, and so thank you for being here today. And I know you're going to give a wonderful presentation to a very scholarly group of individuals. And you're coming to our campus at a really neat time. We just had a groundbreaking yesterday, had the governor here and a lot of the president of LSU and a lot of dignitaries to a new $60 million medical education building. Hopefully when you come back for your next visit, that building will be complete and you'll be able to see that. And this conference will be able to be conducted there as well. As you know, we also just celebrated the 1-year anniversary of the partnership with the Ochsner Health System as our hospital partner. So there's been a lot of changes going on here. I applaud the neurosurgery department. They in particular have gone through a lot of changes over the past 2 or 3 years, and I really applaud them for their cohesiveness and for their cooperation. And applaud Barat and the entire department. So without further ado, I welcome you, Dr. Jabbour, here, and know that you will bring a lot of knowledge to this group, and thank you for being here.
Good morning, everyone. Thank you, Dr. Golly, for taking the time to visit with us and for the introduction. I just wanted to say a few words about kind of why we're here today. The Woodard Symposium is one of our 2 main kind of endowed professorships each year. It was born from a patient that we as a group took care of 10 years ago, who suffered a ruptured aneurysm, was treated, actually Dr. Willis, it was one of Dr. Willis's patients who had a ruptured aneurysm, was managed by Dr. Willis, and was treated endovascularly by Dr. Michael Williams, who's our pre-existing endovascular colleague before Hugo joined us. And so we've had this symposium now, this is the 10th year, or 8th year, I believe. And 2 years ago, we decided to make it kind of focused on, where it was born from. So we've had, you'll be the second visitor whose kind of primary focus is vascular and endovascular treatment. These types of opportunities for us are excellent. We kind of get used to doing and seeing, our routine day-to-day work, and it's always nice for that to be broken up by a day like this where we can learn from you and learn new techniques and see how experts around the world do this. So I wanted to thank you for joining us, and also wanted to really compliment Hugo Cuellar, who really put this together in terms of the science behind today and the organization of today's academic program. and for all you've done for our department, and for he's really made endovascular neurosurgery here a top-notch place. I also wanted to thank all that were invested in putting the logistics and everything that you'll see today and tonight for our group. I see Deanne is in the audience. Thank you, Deanne. And then Christine is in the audience. Thank you so much. And Terry and Jessica, who I think are upstairs manning the office. So they really put a lot of hard work into this. So we're looking forward to your day, and thank you for joining us.
Good morning, everyone. I'm Dr. Cuellar, and I'm the director of the Neurointerventional section here at the Neurosurgery Department. I'd like to welcome again everyone to our Woodard Symposium this year. This day, we're going to have two sessions, one morning session that is going to be focused on arteriovenous malformations, and then Dr. Jabbour is going to have the afternoon session focused on the dural arteriovenous fistulas. So I'd like to invite you to come to both of them. So please join me in welcoming Dr. Jabbour. Dr. Jabbour was graduated from the St. Joseph University in Beirut, then School of Medicine. Then he went on to do his neurosurgery residency at University of Colorado and Thomas Jefferson. He then stayed at Thomas Jefferson University to do a fellowship in neurocritical care and endovascular neurosurgery. Where he is now is professor of neurosurgery. He's the section chief for the cerebrovascular section. And well, he's nationally and internationally recognized. He's presented everywhere. At one of these international meetings is where I had the pleasure of meeting him and talking to him. He's trained a lot of residents in endovascular neurosurgery, one of our own, Dr. Story. So we were hoping he did a good job there. And well, Dr. Jabbour has authored more than 300 papers, 3 textbooks, and he's very, very knowledgeable in neurovascular diseases. So everyone, please join me in welcoming Dr. Jabbour.
Thank you. It's a great pleasure and honor to be here. As you know, residents graduating from a program are the witness of how good of a program it is. This thing doesn't lie when you see a resident and you see the resident working. So I'm saying this because this was my experience and our experience with Chris Story, who was our fellow last year. We were all very impressed by his ethics. We were very impressed by his skills. We were very impressed how dedicated and how hard worker he was. And he was trained so well, actually, in both. I wasn't sure he needed any fellowship, actually. He spent a lot of time with you, Hugo, and then I remember when I was busy and I had an open case, I would be really happy to put Chris up in the open room, despite the fact that he wasn't there to do an open fellowship. But when Chris is there with the resident, I was, relaxed, like, fine, Chris is there. He'll take care of the endarterectomy or he'll take care of the aneurysm. So again, I think this is a prestigious institution. The department under your leadership really is impressive, and I'm very happy to be here. So I'm gonna be talking this morning about AVMs. It's really a huge topic, and I don't think 1 hour is enough, but I tried to trim down my lecture. And we're going to be looking to AVMs through the 3 perspectives of open surgery, endovascular, and stereotactic radiosurgery. Those are my disclosures. So once upon a time on an island in the Caribbean, right? We've all heard that, and Aruba, came in. And everyone was living happily until Aruba came up and then changed really the way we do AVMs and the way we think about AVMs, to the point that I think maybe they noticed in Aruba that their tourism really dropped a little bit because of that. So as you know, Aruba was the trial that a little bit looked at unruptured AVMs and tried to randomize those patients between medical therapy, which we all know what's medical therapy for AVM. There's no medical therapy. So it is just watch the AVM and see if it's going to rupture or not. And the other arm would be treatment, where they said treatment, as if the treatment was homogeneous. Like when you're doing a trial, you're trialing placebo against a medication, or you're trialing a device against the older device or different generation of device. But here it's treatment, and you need to figure out what treatment is that. Is this surgery? Is this endovascular? Is this radiation? Well, it's treatment. It's all together. Nothing is homogeneous in that. So as you know, Aruba showed that the medical management alone is superior to medical management with intervention. And this is after follow-up of how long? 33 months. We all know that 33 months is a little bit short. You know, your risk of rupturing an AVM is the risk of a lifetime. It's not 33 months. It's as if you think, for example, a lot of times we're in a situation where we see a patient with an unruptured aneurysm that has also cancer, right? So we pick up the phone and we talk to the oncologist and we say, what do you think the life expectancy? Is it worth it to treat this aneurysm? So practically here, the patients were patients. All the patients enrolled, you can think of them as cancer patients that had 33 months of life expectancy. Well, if all my cohort are cancer patients with 33 months of life expectancy, in general, I would tend to say, you know what, nothing to do, because I'm not sure we're able to change the natural history of the AVM. So anyway, and there were so many editorials about it, and I'm not going to spend a lot of time, but I think we cannot talk about AVMs without talking about Aruba. And then we wrote our own editorial, and we looked also at eligible patients in the literature, Aruba eligible patients, and we did a big meta-analysis and looked at those patients to see like exactly the same inclusion criteria than Aruba, and we wanted to look at that. So the concerns, as you know, as I said, is we're generalizing the method of treatment, which it's not a homogeneous method. There are 3 different methods. And compared to something that's really homogeneous, which is watching it, everyone will watch an AVM the same, right? It's not like you're comparing it to something else. And different grades were mixed. They didn't provide any outcome according to grading. They didn't even take into consideration association with, what's the biggest risk of rupture is association with aneurysms, right? So they didn't look into that. So only 5 patients had surgery in the whole Aruba, and so only 5 patients had immediate cure. As you know, when you're evaluating a therapy, for example, let's say stereotactic radiosurgery, how long it's going to take for an AVM to be cured with stereotactic radiosurgery? 2 to 3 years at least, right? So you cannot evaluate this treatment modality and say we did the stereotactic radiosurgery, but the patient ruptured 2 days later or a year later. Well, again, this is not fair because it's going to take its time. So only 5 patients had immediate cure, 30 embolization, 31 radiosurgery, 20 enrolled in the treatment arm but never received any treatment. And those were counted in the treatment arm, okay? So there were so many AVMs with feeding aneurysms. What should we do to those? And same. So when we looked at all the literature of patients, Aruba eligible patients, as you know, in Aruba, 30.7% symptomatic stroke or death in the treatment arm. Well, in the treatment arm of all those patients, it was around average mean 8%. In the therapeutic arm of the patients that were treated, which is compared to the medical arm of Aruba. So if you look back at all those patients treated, it didn't really make sense why one trial would show this and everything else showed something different. So what would you recommend to a 35-year-old patient who had an incidental finding after a motor vehicle accident of an AVM, you know, a grade 3 AVM? What can we say? So as you know, the natural history is not benign, and the risk of rupture is anywhere between 4 to 6% per year. And as you know, there's an equation to calculate the lifetime risk of rupture if you want to give an estimate, which is the 105 minus age. Okay, and then again, once there's a rupture, there's a 10% risk of mortality, 30% risk of morbidity. And again, when you have a young patient presented with an intraparenchymal hemorrhage, and you need to rule out an AVM until proven otherwise. So rupturing, as you know, rupturing an AVM is not something benign, and the numbers are really high. But again, don't let AVMs intimidate you, because sometimes, you know, you look at an angiogram, you look at an MRI, and you see all those dilated vessels and all those draining veins, and you can kind of be intimidated by it. Well, and sometimes the treatment is simple, and all you need to do is go disconnect a small fistula to take away huge venous varices that intimidated you. But at the same time, you should know your limits, okay? And if there's anything good in Aruba, it was a wake-up call. I'm not saying Aruba is completely bad, and we're going to talk about this. There are some good things and bad things in Aruba. And I think Aruba a little bit showed us this. You know, before that, anytime we would see an AVM, we would go in and jump in, and everyone wants to treat those AVMs, not thinking about what's our ultimate goal. There's no such a thing of reducing the size of an AVM, which unfortunately I see it all the time. Patients went around, shopped around, they had a big AVM, and it's like, yeah, it's not gone, but they told me that we reduced it in size. Well, I'm not sure if we did any benefit to the patient to reduce it in size. It's either it's a 0 or 1. Either you cure it or not. And if you start your planning treatment and you know that you're not able to treat this AVM, you'd better stop and just don't treat the AVM. Sometimes the natural history of the disease is less risky than the treatment. So not just in AVM, in any disease, if you need to really evaluate the natural history of the disease, you need to evaluate the risk of your treatment. And then again, are you able to beat the natural history? If you are, go ahead. If you're not able, you know, step back. So as you know, the options here are not a lot. There's either, you know, microsurgery or embolization, stereotactic radiosurgery, a combination, or watching, which they called it the medical treatment. Let's start with surgery. So surgery is an effective way of treating aneurysm. This was our 264 cases that we published now more than 5 years ago of surgical resections of AVM. And as you know, this used to be the gold standard before having the embolization and the stereotactic radiosurgery. And it's still in some places, it depends if you believe in embo cures or not, and we're going to talk about this later on. So we looked at 264 patients, 96 were grade 3 lesions, so a third were grade 3 lesions, and a third underwent pre-op embolization. So a pre-op embolization is important. It depends on the AVM. If it's a straightforward AVM, I'll show you some cases. Of course, you don't want to add the risk of embolizing it if you think that resecting it is a straightforward shot. But sometimes you really need, if you have deep feeders, you cannot get control of those feeders, at least you need to try to embolize those deep feeders before surgery. So severe morbidity was around 2%, mortality 2.7%, 86% were discharged in favorable condition. And we were able to get an obliteration in 100% of the cases, yes, because this is, you know, surgical resection. This was the epidemiology. I'm going to go through that. So 45% were ruptured AVMs from the treatment, and those were the Spetzler-Martin grades of that. And as I said, some patients got a combined treatment, so some had pre-op embolization, some had stereotactic radiosurgery, and we had to take them to the operating room and resect those patients. So the patients that had stereotactic radiosurgery, it's either the AVM didn't respond at 3 years, or those patients that developed some, you know, inflammatory changes and cystic changes, I'll show you later on, after stereotactic radiosurgery, where those patients sometimes need to be decompressed. So those were the grades. There were 15 high-grade AVMs, grade 4 and grade 5. And what was associated with worse outcome? It's the number of embolization. As you know, if you embolize multiple times an AVM, and this is mainly in large AVMs, high Spätzler-Martin, increased in the AVM size, and unruptured at presentation. Unruptured at presentation because this is when you can really hurt the patient, because all those patients were intact. So as I said, all the patients were cured completely. We had 86% modified Rankin scale 0 to 2, and no patient had really a hemorrhage after surgery. Once the AVM is resected, that's it. So this is a case of a grade 3 ruptured AVM. Those are cases where they present with a rupture. It depends of how big is the hematoma. You see those embolizations. We're embolizing progressively, and then there was still a residual AVM there. At that time, we decided to take the patient to the operating room. So you can have different strategies. One of them would be to, if it's an unruptured AVM, to embolize as much as you can the first day and take the patient the next day to the operating room. In ruptured AVMs, in general, if the patient is not herniating, you can wait a week or so and then plan your treatment if the goal is not to decompress the patient at the same time. So as you see here, you're going to go around the AVM. I'm sure you've done AVMs, and you need to go first with the feeders. You need to keep the veins until the end. You cannot go and just clip a vein because you're going to create a volcano, and then at the end the AVM would be hanging with the draining vein. You would clip it and remove the AVM. Intra-op angiogram all the time. This is really even more than aneurysms. We would do intra-op angiogram on every case. Another patient that presented with the right-sided temporal AVM. The patient got embolized, and then there was a residual. At that time, image-guided, same thing. That's mainly the arterialized vein. You see it here. And then we're going to go in, same thing. Try to identify all the feeders, go around it. Clip those feeders, go around the AVM, keep the vein. That's the vein. Keep the vein hanging until the end. And then clip it, and then resect the AVM. That's the AVM. The cavity really needs to be like my chairman that Pete Campbell knows. It's like dry like the Sahara. Any AVM resection, if you think you resected the AVM but there's still some bleeding, it means you need to keep on going because you're leaving residual AVM there. Functional MRI is really an important tool in case you're operating in an important eloquent area. This is a patient with a ruptured right frontal AVM. That's the angiogram showing the AVM. So this patient actually presented with an isolated ipsilateral third nerve palsy, and this was really an unusual presentation. Initially, when the patient came in, we thought the patient would have an aneurysm or a PCOM aneurysm. Then, if you look a little bit here, you see that the draining pattern, the draining vein, it has a big dolichoectatic draining vein compressing the third nerve. And we ended up resecting this AVM. There was some feeders from the middle meningeal, from the external also, as you see here, and that's all the draining vein. And same thing, we had in this case to dissect the Sylvian fissure all the way down, go around it. Same technique, from the arterial side all the way, clip, and then resect it at the end, and then do the intra-op angiogram. And this patient's third nerve improved after surgery. It was because mainly compression. So ICH with mass effect, in those cases we don't have a choice. In general, what we try to do is go in, try to decompress the patient, but you need to be ready. Those cases are in the middle of the night. No one of us would like to dive into a high grade or any grade AVM in the middle of the night where you don't have your team and everything. But again, you know, your goal is to try maybe to do a decompression, but you need to be ready. You need to have the microscope, you need to have everything ready, the clips, the tools, because in case this AVM is going to rupture again on you, you need to be ready to resect it. This is one of those cases and in those cases, what we do is sometimes we put the patient right away in the OR, we have a CTA, and then we shoot an angiogram, a one vessel on the table while the patient is pinned, an intra-op angiogram, just to see what we're dealing with and to be ready for everything. So this was shot on the table. And you're going to see the hematoma being delivered and the AVM resected, and this is the ICG green showing that there was no more shunting of blood, and the intra-op angiogram. We always do, as I said, intra-op angiogram in our AVMs, in our aneurysms. It doesn't increase the risk. Once you start doing it on every case, it won't be a production to do it whenever you want to do it. So if you stop doing something you're doing routinely, each time you want to do it, it's going to be a big deal. But here it's just really smooth because everyone in the OR is used to that. So, you know, surgical techniques, we didn't have a lot of new advances in surgical techniques the last decade as compared to endovascular or stereotactic radiosurgery. So in endovascular, we have the dual lumen balloon microcatheters, and those really changed the way we treat AVMs. Those were game changers. I still remember when I was a fellow, we looked at our series of complete cures of AVM, and we were happy. It was like, wow, it's around 20%. By that time, with NBCA, the old glue, having a complete cure, having a 20% complete cure was something really high. But now when you look at it, it's really obsolete with everything else. So I don't know if you're familiar, but there are those microcatheter balloons where you go in, inflate the balloon to prevent reflux of glue and liquid embolic, and you're able to push your glue real distally. Detachable tip catheters, one of the issues were how much reflux around the catheter you can tolerate, because you can get your catheter stuck up there. Well, guess what now? You can just leave the tip there and pull your catheter. The new concept of transvenous embolization, and this really started in France, in Limoges, and then more and more people are doing it. Are you doing any transvenous AVM embolization? Yeah. It's a little bit controversial. I remember one time I was at the WLNC and they were showing this live case from France, and practically the patient ruptured on the table, and they had to take him to the OR right away. So again, pressure cooker technique, right? This is another thing. I'll talk about it a little bit later on. Those are new concepts that came up. So this is the detachable tip catheter. Those are the balloon catheters, you know, that you inflate the balloon and you inject in it. And you all know what that is, the old-fashioned pressure cooker. So pressure cooker technique, which is combined with transvenous. So practically, there were some ideas going that AVMs are a venous disease. If you think about it, when you're embolizing an AVM from the arterial side, you're not completely done until you have reflux into the vein. This concept was more known in the fistulas, and we're going to talk about it in the afternoon. You're not cured until you are able to push your liquid embolic to the vein and obliterate the vein. Well, if you think of AVMs that way, that you need to really cross the nidus and then get your liquid embolic to the vein. Once you do this and you shut down the nidus, it means you really cured the AVM. And sometimes the vein is a straighter shot to the nidus than the arteries, right? Because in general, AVMs have multiple feeders. They go to a nidus, they converge at the nidus, and then the AVM would have one draining vein or two draining veins or maximum 3 draining veins. And those draining veins emanate from the nidus right away, and they are big vessels. It's not like the feeders. They go in tortuous and they become small. So if you think about it, if you can navigate through the vein, and the vein will put you at the nidus, and if you can somehow, what's the problem when you're doing this? You're working against flow. You're swimming against a river. So if you can somehow reverse all those hemodynamics and get your liquid embolic to move from the vein to the nidus, at that time, maybe you're able to cure those AVMs. knowing that at the same time, this is like a board questions, right? What are some of the risk factors of rupturing an AVM? Right? Single draining vein, stenosis of the draining vein, or early occlusion of the draining vein. So you're there in the vein and you're injecting liquid embolic, you run the risk of shutting down the vein while your AVM is still alive. At that time, your OR need to be ready because you need to take the patient right away to the operating room before even waking him up. So anyway, so the concept of transvenous is that. Now the concept of pressure cooker, the pressure cooker came up, they wanted a way of reversing the flow and trying to get your liquid embolic to go to the nidus. At that time, what happened is, what if we start decreasing flow of those AVMs? It means we're gonna start catheterizing, okay, all the feeders, and we're gonna either shut down feeders, something that we wouldn't do, like shutting down proximally a feeder, we wouldn't do that. So you can do this, or you can inflate balloons, which shut down temporarily the feeder, inflate a balloon there, and then keep it there. Don't do anything from there. In case you want to complement your transvenous approach, you can start embolizing from there. So until you create a closed system, the AVM would be like a pressure cooker, it's a closed system, and then you try to go up from the venous side, put a microcatheter there, and try to inflate a balloon or put some coils proximally to decrease the venous outflow. So at that time, you're decreasing the flow of the AVM and you're changing the hemodynamic. That's what you see here. So this is just an AVM with a fistulous component that we were able to treat with just a balloon, not a pressure cooker or anything. And as you see here, so before those balloons, we used to have hours of injection. I mean, I'm sure, Hugo, you've been through that, and a lot of times, a lot of us are ADD and we cannot wait, and Onyx used to be, you need to pull the plug, you need to wait, and sometimes hours of injection. Here, it's totally game changer. You inflate the balloon, if the liquid embolic is going forward, you just push. And here it is, this is a 1 minute push, and it's gone. This is a case of a subdural hematoma. Patient presented with spontaneous subdural hematoma. Turned out that the patient has an AVM, as you see here, right temporal AVM with the draining vein, all those feeders from the anterior temporal and the MCA. So as you see here, this is the microcatheter, balloon microcatheter, and here it is, it's completely gone. Another case of a little bit of subarachnoid hemorrhage. You see here the you see the AVM, same thing, balloon inflated and the glue is going, and those are all 30 seconds, 45 seconds injection, and again, it's gone. Now, I can say angiographically, the AVM is gone. I still cannot say cure, right? What do I need for a cure? I need long-term follow-up. And we believe in cures. Again, it's a controversy. In some places, they would go and resect this AVM. After it's completely gone angiographically, they would go in and do a resection and resect it, just the cast practically. We do not do this. We followed our AVMs, and I think if you have a 1 year follow-up, in general, your risk of recurrence is less than 1% if you have a 1 year follow-up showing that it's completely gone. This is a case of a IVH from an AVM, and as you see here, it's an AVM fed by the PCAs. It's a posterior callosal AVM, and fed by the ACAs. And in this case, we decided to go transvenous. So that's the lateral view. We thought that the feeders weren't really, we didn't have big feeders enough, and there was a vein going all the way. So this is here navigating the balloon all the way from the venous side. And our system was, so we went transradial, we went transfemoral, and we went direct IJ. So we wanted to go and inflate a balloon at the ACOM area. Then we wanted to go to the posterior circulation and inflate a balloon in the PCA, which is the other one. So we went transradial there. We went transfemoral to the ACOM with the balloon. And then we did a direct IJ stick. So usually in those cases, we do direct IJ sticks because you have more support instead of going up with a catheter. And then what we do with those is you pull on the microcatheter with some tension, you cut it, and you leave it there. And there's no issue with that. So this is our system here. And then you're going to see, I don't know if you can see it, but you see a lot of, it's crowded with microcatheters, right? You see here on the lateral view, a lot of microcatheters there. That's how you're going to be able to achieve that. And then you'll see an inflated, where it is here. That's the balloon inflated at the ACOM. We inflate a balloon in the PCA. And you see here, that's the balloon inflated, and here we're deploying a coil proximal. We have two microcatheters from the venous side. We have one microcatheter in the end of the vein at the nidus. We have one microcatheter proximal to be able to build those coils and decrease the flow there. And then we inflate the balloons from the arterial side, and we start injecting from the venous side. So this is the microcatheter, and you see the liquid embolic, the onyx here, is starting to flow anteriorly. And we're going to keep on injecting. As you see here, it's going. And you're going to see how it's going to go really anterior. So now we're filling nidus. So it's going from the vein all the way to nidus, as you see here. Here it is, all the way to the nidus. Keep on going, and that's what we have. Okay, so we have exactly how the nidus looked like with our liquid embolic, and here it is. At the end, so another case of a patient with a large frontal hemorrhage that presented with a ruptured AVM. What happened is this patient went to an outside facility where they didn't have any neurovascular specialists, so the general neurosurgeon of the hospital did the right thing and decompressed this patient. This was a 25-year-old patient, so what they did, they went and decompressed the patient and transferred the patient to us. If they didn't do that, the patient would have been, would have herniated. So as you see here, I'm navigating the balloon, and you see it goes through tortuous anatomy all the way with the balloon microcatheter. And here it is, the balloon is inflated, and you can see the liquid embolic going forward all the way until you reach the vein. Here it is, and that's your cast. That's going to look like the nidus, and that's the final result. Another case of a large posterior fossa AVM. Patient came in with dizziness and was having multiple falls. In those cases, what we do is, we talked about surgery. Surgery wasn't really a good option. On the MRI, the AVM would go and the veins are all the way going deeply. So we decided to do pre-op embolization, then a stereotactic radiosurgery. This is also a controversial subject. And as you know, that the cure rate when you previously embolized is lower than if you're doing just stereotactic radiosurgery without previous embolization. But again, also we looked at our series. I'll show it to you. And if you don't have any other option, this option is feasible. Again, navigating the balloon in tortuous anatomy and inflating the balloon. You see the balloon inflated, and then you see the liquid embolic going really and deeply in the nidus, as you see it here. Same thing, finishing all the way. And then the patient ended up having a residual, went and we targeted the residual with the stereotactic radiosurgery. So Let's move to radiosurgery. Radiosurgery, as you know, it's all related to the volume, to the size. So a 30 millimeter nidus is around 6.3 cc's of AVM, and we know that the cures are, if the volume is less than 1 cc, is close to 100%. 1 to 4 cc's is 85%, and 4 to 10 is 58%. So in general, we try to limit ourselves to niduses that are less than 4, maximum 5 cc's to have a higher chance of curing. If the nidus is bigger, you have two options. At that time, you can do volume staged, which you would divide the AVM into volume, and you treat each volume as one AVM, separate AVM. Or you can do a dosage, stage the dose, and do the whole AVM, but give small dosages. So in general, if your surgical morbidity is above 12% or mortality above 4%, you'd better offer stereotactic radiosurgery. We had 95 patients that were treated with staged embolization, followed by stereotactic radiosurgery over 15 years. The median AVM volume was 28 cc's, and the grades were 50% grade 3. And those are the results. Overall morbidity 13%, minor complications 12%, major complications 1%, and we've seen some post-treatment ICH because, as I said, it's not an immediate cure. So the negative predictors for a cure are large AVMs, deep venous drainage, increased number of embolizations, and increased numbers of stereotactic radiosurgery. So you see this is the post-treatment progressive angiographic cure. As you go along, it will increase, and those are, cases. This is a small AVM. Again, we targeted. Same thing, another one. Here it is. 3 years follow-up. It's completely gone. Another posterior fossa AVM, same thing, large one. We did a volume stage, and then on follow-up. So it works, and I think this is an option to keep in mind. Now, a little bit cautious when we offer it to someone with a ruptured AVM, because as you know, in ruptured AVMs, you need an immediate cure. And again, I'm not talking about ruptured AVMs with mass effect where you need definitely to take them. I'm talking about somebody that ruptured, that doesn't need to go to the OR for decompression. At that time, stereotactic radiosurgery shouldn't be your first option because, as you know, the patient will be at risk the first 3 years. This is another case. Same thing. Also, a 2-year follow-up was completely gone. Now, dosage. There are different schools of thought, and in our practice, we have someone who would like to use high dose, another one would use medium dose, one is on the lower end, knowing that, if you're going to increase the dose, if you're going to give an AVM more than 21, 22 at that time, you're going to run the risk of, you're going to cure the AVM, but you run the risk of having problems like this. So this is a patient that had this left temporal AVM, was cured completely with stereotactic radiosurgery, but 5 years later, she started coming with worsening speech, worsening hemiparesis, with those microhemorrhages. Each time we would do an angiogram, no AVM, no early draining vein, nothing. And she even had an aneurysm that we treated. And then this patient ended up needing a decompression because of all the cystic component, all the magma, inflammatory magma. And I've resected at least 5 or 6 of those. They are dead AVMs, but they create this kind of cycle of inflammatory edema. And the patient, and in general, really, they don't do well, even with a decompression. Cystic degeneration after stereotactic radiosurgery without needing a decompression, but needing a shunt. So I have a couple of cases where I needed to go and do a cysto-subarachnoid shunt. This is a case where the patient presented, started having speech difficulties. We did an angiogram, the AVM is gone. And in this case, what I did is just a cysto-subarachnoid shunt. I just put a tube, and then now it's been 4 years, and it's been well. So this is another case that came to me with this AVM, and an angiogram was done. showing this big AVM with a lot of venous varices. This guy was a truck driver. And at that time, we sat down, we talked, and we said, this is a major one, and let's watch it. He didn't have a lot of symptoms. Then he presents a year later with aphasia and hemiparesis with this CAT scan. Now, those are calcifications, and he had small hemorrhage. Now, not all this is hemorrhage. Those are some veins, and I'll tell you why. So I do an angiogram on him. Didn't even do anything, right? So sometimes the nature takes care of things. So what happened, this guy presented because he was thrombosing his AVM spontaneously. And here you could still see some early draining vein, as I'm going to show you here. So it's not completely gone, but you see some vein here. And the guy was symptomatic, and we did an MRI, and the majority were thrombosed veins. The hemorrhage was just there. So we watched him, and then he improved, and he went to physical therapy and did everything. Then he came back. I said, I'm going to repeat your angiogram, see where we are, see if we need to do anything. And this is a 3 months follow-up angiogram. Completely gone, no early draining vein, nothing, and we didn't do anything, so he did it to himself. So of course I'm going to follow this patient further and repeat an angiogram at 1 year, but again, sometimes just watching and not being aggressive is also something good. I remember when this patient was at the hospital, we presented the patient, there were a lot of debates, what to do, and then you know what, he did well. So this is the case that was sent to me. Saw me in clinic for this. You see this nidus here. And you see that. So we did an angiogram. What do you guys think? Let me repeat the run. Who's the chief resident? All right. What do you think? What's that? Yeah. So this patient turned out that she has a tumor, and this was when the fellow was doing the angiogram, they called like, yeah, we found the AVM, but it's a little bit unusual. Like there's some early draining vein, but I couldn't determine the nidus. It's thrombosing. I look there. When you look at it, it's like this is a typical vascularization of a tumor. And sometimes you will have some shunting in some tumors. You can have shunting. That's not really unusual to have shunting. But the patient turned out that the patient has a GBM, right? And then all those vessels are coming to the tumor. So just, be careful. Not because they sent you the patient with a diagnosis. Sometimes we tend to, we have a patient being sent with a diagnosis. We go full speed working up this diagnosis, and sometimes it's something different. One time I remember they sent to us a patient for subarachnoid hemorrhage and acute hydrocephalus. We look here, we see some hyperdensities, but patient has a colloid cyst and acute hydrocephalus from colloid cyst. And the patient already, when I came in the morning, had already CTAs and all kind of stuff. And so again, just try to analyze that. Smoking, we talk a lot about smoking with aneurysms, but smoking also decreased the risk of response and cure of AVMs. We looked at 774 patients, and we looked at the smoking pattern, and smoking plays a role in also AVMs. So you should counsel your patients not only for aneurysms. So I think As a conclusion, the natural history of a brain AVM is not benign if you follow long enough, right? It may be benign if you follow 33 months, like what they did in Aruba, but it may be not so benign if you follow for a lifetime. We need to definitely, Aruba was a wake-up call. Aruba was a wake-up call that we, as a neurointerventionist, we definitely need to bring our M&M down to justify treating the AVM. And if I know, as I said earlier, that I won't be able to treat this AVM at the end, I won't be able to cure it, I should never offer a treatment. It doesn't make sense to do 6 sessions of embolization and then say, okay, we reduce the size. To the opposite, you're changing the hemodynamic, and this may increase the risk of rupture. So really, look at your ultimate goal and then decide what you're gonna do. We are able definitely to cure more and more AVMs with all the new techniques that I showed you. It's definitely, it should be a tailored procedure. With all those techniques we have, we should be able to tailor a treatment plan for every patient. And, not because we have the tool available, we should offer it to all comers. So this is very important, not only in AVMs, but in everything else. And at the end, I think technology is a double-edged sword, so really be aware of that.
Emma. 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 Emma.
Thank you.
Thank you for a great talk. Any questions?
I was very interested in the case in which you did the transmitted embolization in AVM and you did the inclusion of the feeding arteries.
The balloon I use?
Yes, you did balloon occlusion for the feeding arteries. So it's kind of like basically a temporary clip on
Yes.
the major vessels.
Yes.
So is there a time limit or do you do it under monitoring?
So we do it under monitoring, and all this took 5 to 6 minutes of injection. But we do it under monitoring. What did I use? Onyx 18. Yeah. And then we embolized a little bit from one of the feeders with the balloon, because at the end, when we finished completely, we saw that the anterior part of the AVM was still filling. So the balloon was still up. We injected a little bit. It went directly to the part that's filling, and then we pulled out everything. Yeah, no problem.
Can you speak on the timing of surgery?
So,
In rupture cases.
yeah. So, I mean, obviously the one that's herniating, that's not an issue. The one that come in with a hemorrhage, as you know, this is not an emergency. In general, we let them recover and then we bring them back. So we would do surgery in the coming 2 to 4 weeks in general. Now, also case by case, because sometimes you have the hematoma that already dissected everything and the patient is already, one of my old mentors said, you operate on them when they are doing bad because you cannot hurt them, right? So you have the hematoma, the patient already has a poor neurologic status, so you go in and you do what you need to do. Another school of thought is, try to let them recover a little bit, let them have some neurological recovery, see how they're gonna do, and then go in. But definitely, it should be in the coming. I wouldn't wait more than 6 weeks for that, because as you know, the risk of re-rupture and everything. So. So that's very important. We didn't talk enough about intranidal aneurysms. Definitely, a patient with a ruptured or with a hemorrhage and an AVM with an aneurysm, you need to definitely treat the associated aneurysm first. Now, you do it acutely, you do what you need to do, and then if you want to tackle the AVM later on, you will wait, bring them back. But aneurysms that are risk features for rupture, if you are able to treat those aneurysms first alone, you would treat them. If you are not able and you have an intranidal one, you'd be more aggressive treating this AVM earlier.
And all of this work you do with monitoring?
All we do with monitoring, yeah.
The endovascular and
the endovascular and the open, yeah.
Okay, we thank you.
we have an AVM and we actually know that one of those internal aneurysms have ruptured, and we can target it, we just go and target it, do it, and then wait.
Yeah.
As you mentioned, this venous axis is still a little bit controversial.
Yeah.
So when you see an AVM, what's your thought process to decide, well,
Yeah. Yeah. So I haven't done a lot of venous, transvenous AVM. I've done maybe actually I've done 6 transvenous AVMs. I really choose the ones that are good candidates. So in general, I look at an AVM that surgically for me would be also a high risk surgical case that have multiple feeders, but that has really a nice vein that I could access and that I can use and go directly to the nidus. Now, I try to avoid single veins because if something happens, I'd rather have one main vein and another vein or a couple of veins to be like a safety net for me. But in general, those are the AVMs that I would do. So transarterial embolization would be difficult, like racemic AVMs. So the transarterial site is not very obvious, but I have a nice vein plugging directly from the nidus. So those are the ones.
And when you see a radiosurgery case come back and it has not closed, what do you do there?
So if I'm planning a volume stage, I do the volume stage at 1 year. We wait 1 year just mainly because of the radiation necrosis to make sure they are not because you don't want to give another dose if they are into full radiation necrosis. So 1 year, and then I'll do the second dose. If it's an AVM that I did just one from the beginning, I wait 3 years usually, and I follow them with MRIs every 6 months, and then at 3 years I do an angiogram. And once I do the angiogram, I'll evaluate. Either I'll take the patient to the OR, or I'll give another session of stereotactic radiosurgery. Depending on the volume that's left, and if there's how much swelling and things like that. But
what are the types of cases that you find you do nothing?
So after Aruba, more and more we started watching AVMs, and again, because as I said, it was a wake-up call for us about really what's the risk of what we're offering. So definitely a grade 5, unruptured grade 5, even on a young patients, usually we would watch, we wouldn't offer it. Even a smaller grade, but in an eloquent area, like a dominant, temporal lobe, unruptured on a patient that never had symptoms, we tend to watch those. So older patients, definitely, I wouldn't go in, patient that had an AVM all their lives and they saw me for an incidental finding, what's the chance that now at an older age they're gonna rupture it? So that's in general. Any AVM that I look at it and I feel that I won't be able to cure it. So if I think I'm not going to be able to cure this AVM, I'm not going to engage in any type of anything. It's not like, let's start and see what's going to happen. This mentality shouldn't.
Yeah. So now do you use like pre-embolization for all your surgeries, or there's certain people?
No. So grade 1s and 2s in general, where they are not in eloquent areas where I think it's a straight shot for surgery, I just resect them because it doesn't make sense to increase the risk of embolization, at the risk of embolizing them, and it's not going to help me a lot in the operating room. Grade 3s in general, the majority of them I would embolize pre-op. When I have feeders where I think I won't be able to get to them, deep feeders, I'll try to embolize those at least. I won't be aggressive. So it depends what's your goal. So my pre-op embolization is never aggressive. If I decide I want to do a pre-op embolization, I'm not aggressive because I know that I'm going to the OR to resect it. Why should I go aggressive? Because my goal is not a cure. I'm not going for a cure.
So in that case series that you presented, there was like 100% complication rate. So in the cases that used pre-op embolization, you noticed like the morbidity was better, or like morbidity?
There was no difference in morbidity in patients that had pre-op embolization, but again, we're very selective in what we embolize pre-op. and we didn't find any statistically significant difference in those.
Just based on the easier?
Yeah, because as I said, it makes the surgery easier, and you can get to some feeders, or if it's a high grade, it would reduce it to a lower grade where you can take it to the OR.
I think we had a couple of extra minutes. Can you speak a little bit, especially to the residents, about kind of your philosophy on training, and what you're doing? Your practice is going to be very kind of complex work and difficult technical cases in terms of what the ones who are interested in doing the type of practice that you have. Like, what is your algorithm for training them to be good at both things?
Yeah. So this is very important, and I think at this point, if you want to be a vascular neurosurgeon, you need to be able to do both. It's a little bit like how spine was 15 years ago, more than 15, let's say 25 years ago, where it used to be that only the orthopedic surgeons would put pedicle screws, and then the neurosurgeons would decompress. And then slowly things started to change. And right now, for example, you don't need to do a fellowship to be able to put a pedicle screw, right? I mean, it's not, you all are able to put pedicle screws. Vascular should be the same. You cannot, right now, you cannot say I'm a spine surgeon if you're not able to put a pedicle screw. Same with vascular. I mean, I don't think the future is, you shouldn't need to go do a fellowship to be able to do a stroke or a straightforward aneurysm. I mean, you may need a fellowship to go do those big scoliosis and things, but to do straightforward spine instrumentation, you don't need a fellowship, because this is part of the neurosurgery curriculum. So we've been fighting for a long time, and especially my chairman, to have endovascular part of the curriculum. And it started with diagnostic angiograms. And now, more and more, all the fellows coming, they already have done diagnostic angiograms during their residency, and this is really great. And I see here that you guys are very involved with Hugo, and this is really an important thing. So again, I think gone are the times where we beat on our chest, say, oh, I'm a vascular surgeon, I don't need endovascular, I can deal with this on my own, and vice versa. You cannot be an interventionist and say, who needs neurosurgeons? We don't need neurosurgeons. There are still, if you want to be balanced, there is still room for open surgery, and there are still indications for open surgery. When you go to a place where everything is done 100% in the same technique, know that something is wrong. So I encourage you to be involved in endovascular from the beginning during residency. Like at Jefferson, now the endovascular room is considered like an open room. There's no, priority. Like if you're running an open OR room without a resident, and you're running an open an INR room without a resident, long time ago it used to be, the resident can't go to INR because there's an uncovered OR room. Well, right now, it's more and more, it's up to the resident what they want to do. And more we are not enforcing that. We are considering the INR room like any open OR room, because both are, things that you need to be proficient in. Now, at the same time, again, I mean, if you want to be objective and choose the best for the patient, you need to be able to do both. In places where dually trained neurosurgeons are not available, at that time, really a close cooperation with the interventional radiologist and the open vascular neurosurgeon is important, and this is how you'll be able to manage those patients. But be working really independently, and each one working on their own and trying to push the envelope, because if my tool is the hammer, everything else is a nail, it's not anymore. It doesn't work. Yeah.
In the sense that I want to ask you this question in terms of you being a leadership role in cerebrovascular surgery.
You're sorry.
I wanted to ask this question to you, considering the fact that you are in a leadership role in cerebrovascular surgery presently, and a rumor was published in Lancet. No matter how much noise we make in journals like Modern Surgery, JNS, we are never going to make an
So there were a lot of, but for a while, I mean, after Aruba, you see there are like hundreds of editorials that came out and things and all that. The problem is with Aruba and everything, the problem is there was not enough funding to keep the trial going. That's the thing. If the trial had gone, so two things. If in Aruba we were able to decrease slightly our complication, our morbidity, mortality, and if we were able to follow those patients a little bit longer, we would have had a completely different result. Right now already, our complication rate has decreased and we're able to cure more patients because of the technology. Think when Aruba was out there, we didn't have half of the tools that I showed you, right? So again, we need, is this feasible? I don't know, I'm not sure. If we don't have the money, we don't have the budget, you cannot. We don't want to repeat another trial if we know that we're gonna fall in the same trap. So again, Aruba was a wake-up call, and I like Aruba. And Aruba really was something, as I said, it gave us some insight. It gave some people insight about, listen, you're offering an embolization, this carries risk. Maybe leaving this patient alone is better. If you're offering this and you're not able to cure the patient, again, it's something that's, it needs a lot to be able to plan this trial, because we cannot afford another failure.
Can you speak a little about kind of the development of your consortium of hospitals?
Yeah. So we were talking earlier. So Peter knows. Pete was a resident with us. I was telling the residents, Pete, that our neurosurgery residents evaluate the stroke patients, and they were very surprised. So Peter probably hated at that time, right? But I think this is part of being, listen, we need to all step up and start taking care of stroke. We don't have enough physicians to take care of stroke. They're gonna be around 1.2 million strokes a year in 5 years or so in the US. And we need us as neurosurgeons to get involved in that. We started in 2009 a telemedicine program. And by that time, a lot of hospitals around in the rural areas of Pennsylvania, we used to get those transfers, and those people were all candidates for TPA, but they didn't get TPA just for the fact that they didn't have anyone who would give TPA, because the emergency room physician wasn't familiar with TPA, and we would have a lot of missed opportunities. This is how everything started, and the idea came up. It was like, what about telemedicine? And we started looking at telemedicine companies, and we found a company where it was the only one that was FDA approved. And we started looking, and this, not just to give TPA, this is also to try to be able to keep in the community hospitals patients that don't need to be transferred. I mean, we both are interested in that, right? You don't want to fill your hospitals with patients that didn't need your service, and then once the patient needs to come, you don't have beds and you're full. And the hospitals there, they would like to keep patients there if they don't need to send them. Because before telemedicine, how it used to be, I would get a phone call, like, I have a patient, send him. This is my answer, because it's liability. I don't know. He's talking to me from a different faraway hospital and trying to describe what they have, trying to describe a CAT scan. It's like, you know what, send the patient, we'll figure it out. Well, right now we're very selective, and we are able to log on, evaluate, do what we need to do, administer TPA. So we have now 38 robots in 38 spoke hospitals. And when we first started the program, we didn't have enough people to take call. And this is why the majority of the call was done by neurosurgeons. And I remember my chairman met with us and said, either we want this to succeed or not. And we were young, and we looked at him, it's like, so you want me to give TPA? I mean, I'm a neurosurgeon, how am I gonna give TPA? And now, it's just, I look at it, it's like, it's nothing. Of course you can give TPA. I mean, as a neurosurgeon, TPA shouldn't scare you. So then we looked at the statistics, and we published how many patients we're able to keep there, how many patients are being transferred, and the rate of TPA administration. So during this time, there were around 20% of those hospitals never gave TPA before, and this program led them to start giving TPA. 97% of eligible TPA patients got TPA. And this is an unheard of number, and we published this in Neurosurgery. The overall rate of giving TPA is usually around 10, 20%, maximum 30% nationwide. But I'm talking here about TPA eligible patients, how many receive TPA. Nationwide number is around 70%. We were able to accomplish about 97%. And this is all because we are, all there. We log on, we're ready to go, we're able to evaluate everything, and we're able to guide that. Other than that, it's continuity of care. You log on, you see the patient, you talk to the family, then the patient is being transferred, and then you meet them again, and they say, oh, I saw you on the robot, that's you. And other than stroke, this program was able to increase our transfers in subarachnoid hemorrhages, in tumors, in spine, everything. It's all, the same. So again, I know that you guys think that stroke is not neurosurgical. Well, I was just giving a lecture at the European Association of Neurosurgeons in Dublin. They invited me to give a lecture with the title, Stroke is a Surgical Disease. So stroke is a neurosurgical disease. Stroke wasn't a neurosurgical disease when the only treatment was aspirin, but now it became a surgical disease. And when I say surgical disease, I'm not saying neurosurgeon. I'm saying, because I get in trouble in social media, I'm active, and they attack me. It's like, oh, come on, you guys think everything is surgical. I was like, I'm not saying, if an interventional neurologist treated a stroke, he is a surgeon. Any disease that needs a procedure to be treated becomes a surgical disease. If an interventional neuroradiologist did a case, this is a surgical disease. I'm not saying this is just for neurosurgeons, but we should approach it as a surgical disease. Right? We have the sense of emergency. You neurosurgeons, neurosurgery residents, you have the sense of emergency. You know what's emergent. So it shouldn't be just when you look at a CAT scan and there's a lot of hyperdensity there. In our mind, being trained, this is the emergency. No. You can look at a CAT scan, it's completely normal, and this is a real emergency. So we should go through this mindset, and I think you guys need to be more and more involved in stroke.
For the cases that you do not transfer, but you do need TPA, do you have any kind of follow-up with that, or at that point, that's both hospital cases?
So some hospitals would keep them there, and some hospitals who don't have neurosurgeons, if we give TPA, but the patients are not candidate for endovascular, they'd rather send them to us. So when the patient are sent to us, if I was on call on the robot, the patient is admitted under me. If a neurologist was on call, the patient is admitted under neurologist. Now, I published a paper, I got into trouble for it. I looked at the cohort of strokes being admitted to Jefferson, and I compared outcome between patients being admitted and being taken care of by neurosurgeons and by neurologists. My goal wasn't to say we're better. My goal to say we're as good as you guys, we're the same. We can also take care of stroke. And there was no practically difference. Our patients didn't do worse.
Well, thank you.
Thanks.